Welcome, everyone. We have the pleasure of a group of healthcare providers that are just awesome, that I rely on taking care of my own patients. And if anyone knows me, I'm really particular about who I send my patients to. We have besides myself, I'm Chollkim from the Spine Institute of San Diego. I'm a spine surgeon. But we want to mostly talk about how we treat these patients without having to worry about surgery, or fusion, especially fusion surgery. So we have with us Dr. Jeff Anthony. He's the founder and one of the principals at the San Diego Sports and Family Medicine group, which is a very large group of primary care physicians spread throughout the country, throughout the county, that is just phenomenal at taking care of the patients. We also have Dr. Nathan Miller of Coastal Pain and Spinal Diagnostics. He's been doing pain medicine for a while. He's a lot younger, even though he's got a lot of gray hair. He's really smart. And he's going to help answer questions about what his specialty allows him to do. And then we have Chad Neubrand, who's the Director of Physical Therapy at the San Diego Sports and Family Medicine and Physical Therapy Clinic, right next door to my office. And again, if you know me, physical therapy, exercise, fitness is, I think, such an important part of back care that I'd like him to answer questions about specific issues related to physical therapy, why it works, when it doesn't work, when it does work, etc. So with that, let me give a short presentation about what we're talking about today. The first is that, we want to look at a group of patients that have the following characteristics, because we could talk about back pain in so many different ways. I would like to kind of focus down on a kind of a group of patients that will hopefully speak to many of us. So this is a group of patients that are they're busy, they're actively working still, like me, who has kind of ongoing back pain. They've had it for at least a year, if not longer, and they've tried some PT, some chiro, some acupuncture. They've been trying to deal with this, but bottom line is that they're just busy. They're working, and they're not really able to take a lot of time off to focus on this. And certainly, they don't have the ability to have a big surgery where they miss months of work and take months to years of rehabilitation. They've even gone as far as changing their lifestyle, including changing the way they work. Their workstations are often modified to sit-stand stations. They have special chairs. They've had an ergonomics person come into their office and try to redo everything. And they've also, on top of all that, slowly started modifying their activities. In medicine, we call it activity modification, but it basically boils down to eliminating activities that cause pain. And if some of those activities are activities that are meaningful to your quality of life, that's kind of a big deal. But a lot of us will basically get to the point where all we can do is work. Then we get home, we're cranky, we don't want to do anything, we don't do any kind of fun activities, and it's this vicious cycle where there's nagging back pain in the middle of a very stressful, busy environment. That's basically 99% of all Americans. And we're just muddling through trying to get better, and it's getting to the point where it's just miserable. And if there's something that we could do to mitigate this problem and improve upon it, not necessarily completely find a cure, but to make it better to the point where it's not a major part of your day's concern, I think that would be a benefit. And I'm hoping that this webinar is going to address that group of patients, because this problem is unbelievably common. And it turns out it's significant, both from a personal standpoint and from a societal standpoint. I think most of us either have experienced back pain ourselves or know somebody that has back pain, because almost all of us will have some episode of significant back pain in their lifetime, 3/4, probably even more. Now, luckily, most of those episodes, 90%, they resolve around 6 weeks. Now, 6 weeks is a long time even still, but at least it's temporary. But there are a group of patients whose pain does not decrease, and that number is huge. It's 7%. So if you start doing the math and you think 75% of all adults will at some point have significant back pain, and 7% of those will become chronic at some point in their lives, that's a staggering number. And if you look at that, it's not surprising that it's the second most common reason why patients visit their doctor for something other than like just a wellness check. The number one reason is an upper respiratory tract infection, a common cold, which is pretty surprising, but it's been like this for a long time. And it is the number one reason why people miss work, and it's the number one cost of work disability problems. So it is a significant problem both to the person that's having this back pain, because it can be pretty miserable, and as a society, this is a problem that has broad effects on the amount of availability that primary care doctors and other providers have to see patients because of this problem, and for our working environment where it has a huge cost burden. So let's just ask something basic to begin with, because I don't know that everybody knows this. Where does that pain come from the low back? And everyone just says the spine, but the spine is a lot more complicated than you would think when you first look at it, because it has multiple different components. The biggest thing that we look at are the discs. The discs are the shock-absorbing components between the bones that allow us to kind of jump up and down and vibrate and be in cars and walk without having severe pain of bone crunching on bone. But besides the disc, there are a bunch of ligaments in the disc, in the spine, and around the spine that can cause pain. The bones themselves can cause pain, so this is not the typical patient, but if you're osteoporotic, you can get a compression fracture, what we call a vertebral compression fracture, and that is very painful. And then just the muscle, tendon, bone complex. We call it musculoskeletal pain. That's everything that basically allows us to stand up straight, and all the muscles and tendons that attach all to all the different bones that allow us to move around in three-dimensional space and to maintain an upright posture. So any one of these things or a combination of these things can cause pain. So if you ask the next question, okay, out of all these possibilities, which ones are the most common? This is another surprising thing. Here is a breakdown of the type of anatomic causes of back pain. So here's the disc problem in orange. Spinal stenosis, things like ankylosing spondylitis. Here's that compression fracture. Here's cancer. But this huge part of the pie is what we call nonspecific low back pain. In other words, the majority of people that show up to the doctor's office, the majority of the people that miss work, have back pain due to this weird category of anatomic causes called nonspecific low back pain. That is probably a combination of disc problems, ligament problems, muscle, tendon, bone problems to a varying degree. So I hate that term nonspecific, but when you don't have these specific diagnoses, it generally means there's not a specific treatment or a surgery even. Because if you had a big disc herniation at a single level and that was the cause of your back pain, then this is an easy problem. You just do a disc herniation surgery and many patients get better. But the majority of us are in this big category, which we call nonspecific. So with that background, I would like to kind of open things up to a question and answer format where we hear from our faculty about how they take care of these things. So how do we treat this kind of problem? I would say that the categories are either medical management or non-operative treatment. That would include, I would put in chiropractic care, acupuncture in there as well. And then there's an entire field, an entire specialty called pain management that strives to medically deal with the pain signals. And then finally, if that doesn't work, then there are people like me that are looking to operate and fix things. And these three kind of modes of treatment, each one has a huge variety of strategies that probably depend on the specific unique characteristics of each patient. So we're going to try to make some generalizations, but it's so hard to kind of decide on one treatment or the other until you look at a patient, but we're going to try to answer some questions. So here's the first question. And I'd like to direct this to Dr. Anthony, who's the sports and family medicine physician, because it turns out that the primary care physicians are the ones that see the majority of these patients first. 60% of patients go to them first. So the question to you, Dr. Anthony, is what is like the most common presentation in your clinic? And in a patient that's already tried some PT, that's busy at work, and they've been having this problem for well over a year, and it's not constant, it's intermittent, but significantly affecting their function and lifestyle. How do you kind of go about starting treatment for a patient like that?
So that's a great question, and I could talk 2 hours on this, but you told me not to talk too much, so I'm going to try to cut it down a little bit. But I agree with Dr. Kim that low back pain is extremely common. I'd say I see 2 to 5 per day of low back pain. And he mentioned as one of his first slides is that many times it goes on for a year. Well, those are a lot of times the patients that he sees. The patients I see, it usually doesn't go on that long. So we have the low back pain is extremely common. And he mentioned that non-specific low back pain is probably the main reason for it. But us as physicians, we need to rule out the bad things. So the first thing we do when you come in is we say, okay, what's the worst thing that can be? And let's make sure it's not that. And then we do that through our evaluation. So the first thing that I ask is, what was the mechanism of injury? We do a lot of sports medicine, and that's an important question to us is, how did this injury come about? And so we ask you, what happened to your back? Well, you were fine until when? And what was the mechanism of injury that happened here? Most commonly, it's a relatively mild mechanism. I bent down to tie my shoe and my back went out and I couldn't move and I fell on the floor and then I had to call the ambulance. You know, it's something little that they've done 100 times, but this time it set it off. And that lets us know that most low back pain is an overuse type of a problem. And we'll get into this a little bit further as we talk, but you were kind of a setup for this back injury and things weren't quite right. So that leads us into the next thing is, okay, what's the history? What's your ergonomic setup? That's the most common reason. Choll, if you can go back to the first couple slides that you have, I just want to point something out because we see this a lot. The ergonomic setup, how you're sitting at your desk, how you're sleeping, how you're lifting things, how you're doing things, many times that's the significant etiology for your low back pain. We see this a lot through COVID. Okay, one more right there. So let's go back. No, the first one. Right there, what do you see that you think can cause low back pain? Well, she's at her desk with her laptop computer. You cannot be ergonomically sound just with a laptop because you have to lean forward to use your laptop. And so ideally, we want your monitor to be at eye level as you're looking straight forward. So we want to bring that monitor all the way up to the eyes. Well, now when you do that, you have to bring your hands up so you're doing this. So the only way to do it effectively is to have an external keyboard, an external mouse that you can use to be ergonomically sound. And if you're ergonomically sound, meaning things are set up right, then you have less wear and tear. You get more wear and tear if you're in poor position for a long period of time. That's why we call it kind of an overuse process. So we'll go to the next slide. And we point out here is that we have this guy that's sitting there with, obviously with pain, but look at the guy right behind him. Again, he's got a desktop, he's got a PC there, but he's still leaning too far forward. He wants that monitor to be up at eye level as you're looking straight forward. So these are the kind of things, and Chad's probably going to talk about this later, but these are the kind of things that we need to look at because, yeah, I can treat your acute low back pain right now, but I can put ice packs, I can do whatever, but if you go out and you keep doing the same thing, it's going to keep coming back. So we need to ask the question, okay, why would a healthy person have this back pain that goes on for 3, 4, 5 weeks? Well, because you keep doing something that's making it worse. So the first visit, we look at your ergonomics, we look at your biomechanics, we look at how things are, how you're doing things. Sleeping is really important. If you're sleeping in an awkward position, if you have too soft of a mattress, you're going to keep getting back pain. I had a guy that had back pain after he found out after he bought a Porsche. And after about 6 weeks of driving the Porsche, he continued to have the back pain. He didn't recognize that till we said, okay, when did it start? What are the events around that? And Porsche was one of them. He went back to driving his Ford F-150, no back pain anymore. So how you're doing it, what you're doing is key. We also take a look at what your exercise pattern is. What kind of exercise are you doing? We do know that with back injuries, that the muscles get so tight that it reduces the circulation there. And if you're not doing cardiovascular exercise, and those muscles keep getting tighter and tighter and tighter, and that increases your risk for a back injury. So exercise is important as long as you're doing it correctly, and I'm sure that Chad will talk about that. So we look at the history, and then we look at the exam. And the main purpose of the exam is to rule out the bad stuff. So we do a neurologic exam. We want to know, is this a herniated disc? Is this something that has major repercussions, and that we need to identify things right now? I need to call Choll on the phone right now and say, can you help me out here? So we look at the red flags. If somebody is over 50, there could be a red flag there. Do they have temperature, especially night pain? If you have back pain at night, then that's a warning sign that it could be a spinal tumor, or it could be a osteomyelitis or infection type thing. So we need to rule out any kind of the red flags. After our neurologic exam, if it turns out that this is your regular common low back pain that's non-specific, then we get into management of that. And I think that we'll hit that a lot with physical therapy coming up. So I just open for questions now.
That's really, yep, that's a really great kind of discussion of the things that you look for. So I would encourage the attendees to kind of take that advice and deal with their environment and any triggers. I often will tell patients to keep a diary sometimes, because you may do something on one day, but not necessarily notice the consequences of that activity for a day or two or three because of the lag of the inflammatory process. So I have a lot of patients that cannot sort out why they're having these flare-ups, but if you kind of sit down and interrogate somebody like you do, you can usually find a kind of that last straw on the camel's back that triggered the event, that triggering event, which is usually the last trigger of a multitude of triggers that have been piling up, like you said. They're all set up to have a problem, and it just needs that one little thing.
Can I make one more comment?
I noticed there are people asking about CBD oils and THC. Let's hold that discussion off until we talk to Dr. Nathan Miller, who's the pain specialist, because just in the process of talking about the evaluation, it seems like one of the first treatments that almost everybody undergoes is physical therapy. And in my mind, the idea is simple. We have a musculoskeletal system surrounding our spinal column that's designed to be the world's greatest back brace. So my immediate thought in a patient that doesn't look like they're really healthy and physically fit is to talk about physical therapy. So I'd like to ask the next question to Chad. The question about physical therapy, and let's jump to the question where a lot of the patients that are probably attending this thing has already tried physical therapy. So what are the things that you notice make PT challenging to pursue, and why is it effective sometimes and why is it not effective? And is there something that you can tell us that will help patients make PT more effective? What to look out for and things like that.
Very good. Well, thank you for having me today. Those are great questions. And obviously this is, as many as attendees as we have here, this is a very common problem. I'll say the challenges are a few things. First of all, as you alluded to before, there are many pain generators in the spine, right? You've got the muscles, the ligaments, the discs, the bones. There's many things that potentially could cause pain. And identifying what's causing the pain and coming up with a specific treatment that's effective and consistent is not always easy. No two back patients are the same. And so the challenge from a physical therapy standpoint is really doing a thorough evaluation, doing what Dr. Anthony talked about, identifying everything that the patient's doing in their daily activities, and really getting a full, broad picture of the patient. Like I said, there's no cookbook approach to back pain. There really isn't.
It's customized for each patient. Is that fair to say?
Correct, absolutely. There's an overall fitness level that everybody should achieve. And honestly, the people that do the best with this are people that re-engage in some sort of getting back into shape, if you will, with a specific guided exercise program based on their specific weaknesses, lack of mobility, lack of flexibility. So general cardiovascular fitness program, getting people in shape with a targeted exercise program for what's identified in their physical therapy examination. So, but again, it goes back to, there's so many generators of pain in the spine. Are we getting the right exercise and the right treatment for that person with their pain? And you don't know that until you go through the program. That comes to my second point of what makes an effective physical therapy program is patient participation. And you know, the first time somebody walks in my door and I sit down with them and have this session, I said, I don't have a miracle cure. I'm sorry. I do have an extensive knowledge of what causes back pain. I can evaluate you and give you very specific things to do, but unless you participate and become an effective participant in managing your care, and I say manage your care, really, it's managing the symptoms, staying consistent with what we give you, not doing it for 2 weeks and saying this is not working. Choll sends me patients, and he's, in every prescription he gives me, it's twice a week for 8 weeks. So we at least know for 16 visits that they're going to come see me twice a week and do their exercises for an hour and a half. And you know, after about the 4th week, 6th week, 8th week, they're starting to feel better, and they start to get encouraged. And so Choll always says twice a week for 8 weeks, because that's really what it takes before we identify the fitness level and getting muscles toned and flexible and strong. And so that brings up
a really good point. Besides the customized nature of care, I have a lot of patients that will start PT, they'll get a flare-up like at 2 weeks, and they'll conclude that physical therapy is not good for you, is not good for them, and they will completely stop all exercise and all PT. How do you deal with a situation like that?
Well, so that's a really great point. And that often happens, Choll, where patients, you know, when you start a new exercise program, you often get sore, no matter who you are. You're challenging muscles that haven't been challenged for a while. You're stretching tissue that haven't been stretched, and you're going to get sore at first. And I just encourage patients to, you know, I stress to them, be patient, you know, give it a chance, let me work on you. You know, we do manual therapy treatments and modalities and the things that give us more immediate pain benefits, things that feel good, and those things don't last. You know, what really truly lasts is the consistent home exercise program and getting stronger and flexible again. So when people say,
how much do you think they should be doing at home? Besides the 2 days to come and see you, the other 5 days, what do you recommend?
So again, very specific to the patient, of course. But I don't have patients do an hour of exercise every day, because I realize that's not going to happen. Like you said, people are busy. So we try to stagger it, you know, giving them, you know, walking programs, you know, something that they can do on the days they don't do their exercises, and realizing people are busy and they don't have time to do an hour of exercise. So small amount of exercises that are very specific, and then more broader fitness approach of walking, swimming, biking, you know, running if they're able, but just things that they can stay consistent with and that don't take up too much time.
Perfect. We can talk about that even more, but let's we can go back to it too.
Sure.
Love to hear from Dr. And we have a bunch too. I would love to hear from Dr. Miller, because when I refer a patient to for a pain consult, it's usually for a targeted injection. But my guess is that the breadth of services that you would offer a patient that I described involves a lot more than injections. So just starting out, like, what can a patient expect when they come and see you on the first visit, and what are some of the typical things that occurs, and what are the kind of the most common treatment strategies from a pain specialist standpoint?
Sure. Yeah, thanks for having me. So Dr. Kim, this actually was a pretty good sequence here, because I think this mirrors the way the patients present to the system. They'd see somebody like Dr. Anthony and then be referred to physical therapy. And then to us, we're usually not seeing people with real acute problems, you know, on the first day or two. That's where primary care comes in. And, you know, they've done the work of making sure it's not something really bad like a tumor or something like that, which, it, you know, thank goodness it usually isn't. That's a small percentage of the folks. Physical therapy has happened, and the cases that are going to get better easily have already been quote unquote cured. I'm using that word loosely, but at least made better by physical therapy, and hopefully if they keep strengthening their back, it will be a lifelong a good management skill for them, and it'll take care of it. But for those folks that still aren't getting better, they'll see us. We will try to pin down more finely what the cause of the pain is. For back pain, we'll often divide it into radiating, if it's going down the leg, and non-radiating or axial pain. You talked a little bit about the different structures that can be responsible, but those are kind of the two big buckets. We will do injections, we'll do medical management, and if they're still not getting better, we'll refer them to somebody like you, a surgeon, to take care of that. And just that's a 50,000 foot overview of what we do.
And when is it that what triggers you to send somebody to a surgeon? Like, give me a sense of when you feel like they're ready to talk to a surgeon. Should it be early on, or should it be after you feel like you've exhausted non-operative treatment?
Right. Well, there's some of them where kind of the writing's on the wall. They've got a very, we'll use the term hot disc, and they're just not responding to anything. They're miserable. I had a partner years ago when I was an anesthesiologist, that's my background, who had sciatica, and I saw him. I think I did an epidural injection, and I didn't see him for a few weeks, and came back and he'd had a surgery. And I said, his name was Steve. I said, Steve, usually, non-operative management is appropriate in these cases. And he said, well, I've got a family to feed, and, I had to get back to work, and the surgery worked great. And so the point I'm making is it's not always just a medical decision. But for most folks, they do fall into the category that you want to try to do all of the simple stuff first. And just like we were talking about, you start with primary care and all the fine things, the good things they do. Physical therapy, you mentioned chiropractors is a good choice too for a lot of folks. And then us, and if that exhausts, you'll often try surgery. So those are, again, some of the scenarios.
We have some questions about what I call new age therapies. That includes PRP injections, stem cell injections, CBD, THC, prolotherapy, and there may be a few others out there. What are your thoughts on those types of, I know that's kind of a loaded question, but the specific question that someone asked is PRP injections, but if you can use that as an example of all the kind of the new stuff that's coming out that's not necessarily covered by insurance. What are your thoughts on those types of problems for low back?
Yeah, forget all the old school stuff here. We're going right to the new stuff. Just a real quick anecdote. When I go to our national meetings, we all do, and as little as 3 years ago, it goes under the category of regenerative medicine. PRP is in the category of regenerative medicine. It was maybe one talk at our national meetings, and then it became an afternoon of talks, and now it's all day, every day of the meetings they'll have talks about stem cells and PRP. So it's really advanced. There are a lot of people doing good work out there. I think it needs to be standardized. I think we're going to see a commercial product for stem cells. I was going to say 2 years, but the coronavirus has really put a big wrench in the research right now. So it's probably going to be 2 to 3 years, depending on what the coronavirus does, because we can't do research. PRP, there is some good science there. It has been standardized. You use your own blood. The risks are very small. I mean, you're using your own blood, spinning it down. It was originally described for Achilles tendonitis, and now it's been used for a variety of conditions where you're trying to induce healing. Just to get technical, tendonitis, tendinosis, a lot of soft tissue disorders which can affect the low back, and it has been used effectively. We're waiting for more what's called type 1, level 1 evidence, which are randomized controlled studies for it, but there are some out there. So that's good stuff.
Yeah, that's my sense, that the use of PRP in the extremities has been pretty well studied and validated, but its use in the spine is still really early on.
Right.
So would it be fair to say we have to pursue that line of treatment with caution on a case-by-case basis?
Right. Yeah, I think you're right. I mean, I hate to give any credit to insurance companies, but one of the signs you're going to see that PRP really has got all the bugs worked out is when insurance starts to cover it. And I'm thinking it's going to happen because, there is a lot of evidence for different body parts that it works. I mean, for elbow tendonitis, there's pretty good evidence. A lot of the shoulder stuff, low back, it's still, the jury's still out a little bit on that, but yeah, it is. And I was actually surprised to see in a review article I was looking at that knee evidence for degenerative knees, that PRP is more advanced. There's more evidence than I had suspected. So that's another area. But low back, we still have a little ways to go.
Dr. Anthony, I think you take care of a lot of patients with sports injuries, and I think you do see a fair number of patients that get PRP injections to those areas. Is that true? And if so, what has your experience been with PRP in general? Not just for back pain, but for shoulder problems, knee problems, ankle problems, et cetera.
Yeah. So we do use PRP. We have 3 of our docs that do that. We do not use it for back because we haven't really seen any good evidence on it. We're still waiting for that to come out. But as Nate mentioned, with the tendinosis, it works very well for most people. Now, there's not a great study that says, yes, this works every time, but it does work pretty well for lateral epicondylitis. It works for some of the knee problems. It works for some of the muscle tears if you catch it early enough. But that's about it. It's a lot of things it's just not approved yet. As you mentioned before, it's not covered by insurance. So then the patient needs to decide, is it worth it to pay cash for this? And it may work or not. It depends on if they're the end of their rope. If they've tried everything else and nothing else worked, PRP, as Nate mentioned, is very safe. You're just taking your own blood and you're putting it in there. Actually, it's your platelets of your blood, which are the reparative processes of your serum. And that's where you're putting in the wound. So it's very low risk. It's just a little bit of a cost.
Yeah, platelets and that group of cells that we harvest in that way has lots of growth factors. Okay, we're starting to have lots of questions, so I want to encourage everybody to go to the chat feature. So if you missed it, there's a little ribbon where it says chat. If you click on that, it'll open up the chat dialog box, and you can type in your questions to us. We have a bunch coming in, so can I ask some of those?
Yep. How about a spinal cord stimulator?
Okay, that's a good one. So there's a question about spinal cord stimulators. So here's a patient that has had several facet injections, some ablations, done PT, chiropractic care, PRP, acupuncture, and all those things that it looks like it's helped some, but there's still pain, and so they're considering a spinal cord stimulator. So Dr. Miller, can you just give us like an overview of that field and what your experience has been with that and how dangerous it is and what the overall effectiveness has been and the success rate?
Sure. Yeah. Happy to. Yeah. So
all in like 2 minutes.
Yeah. Traditionally, it was for folks who had spine surgery and didn't get better. And there was an odd nerve condition, complex regional pain syndrome. But those are the big indications. The industry, medical industry in the United States is very advanced, and they sense that this is a big problem. There's a lot of people, as you mentioned earlier, Dr. Kim, that have back pain. And so they said, this is something we want to go after because there's a lot of people who suffer with this. So the amount of money and resources that have been committed to spinal cord stimulation have just gone through the roof. And again, to use my example of national meetings, they kind of recycled the same thing every year for year after year on spinal cord stimulator research. About 5 years ago, maybe a little more than that, it started to go crazy. There's a lot of different vendors out there with different products. They all some of them have different niches, but the success rate overall, I mean, take a 2/3 number. That's kind of a often success rate for medicine. But spinal cord stimulation, overall success rate, maybe the 2/3 number. We do a trial first where we just thread the leads in, sometimes in the office, surgery center, or a hospital even. and try them out for a week. Pull them out. There's no incision. If it works, great. You put the actual unit in at a later date. You make a little incision and put it in. If it doesn't work, no harm done. The trial to implant rate has gone way up with these new units. It's about 80%. And then I won't ramble here, but just one other thing, the durability of these products has also gotten better. We were seeing a lot of late failures in products as little as maybe 5 years ago. And that's really turned around with some of the new waveforms. And we're seeing lasting responses that are going on and on and on. So we're not seeing those late failures as much as we used to. So overall, a great therapy.
Yeah, I mean, I think for the group listening, the two things that I think are important is that one, the DroSakhalin stimulators start with a percutaneous trial. In other words, before they implant everything, they just use a fairly big needle or a catheter needle, and they put the wires in through the skin, and it's just taped outside your body for a few days to basically do a test as to whether or not it will be effective. So the best case scenario is that the patient is having symptoms, they have a trial, and they're really good at monitoring their symptoms to confirm that the trial is really helping them. If the trial's helping them, it just makes sense that the permanent implant will help too. So my experience has been, I get very few people coming back after a stimulator once they've had a successful trial complaining that they're miserable. It's a relatively small number, so that's number one. Having that trial makes it so that if it's not going to work, you don't have to bite the bullet and do the whole surgery. You just pull everything out and move on to the next kind of strategy. The second thing is that with improved understanding of all this computer software stuff, it seems like the type of electrical signaling that they are capable of generating is much more sophisticated now. So I think you're talking about that.
That's right.
That's right. With the improvement in our computer technology among others, I think it's driving that field to be more successful. So I'm glad somebody asked about DroSakhalin stimulators. Again, I would consider that a surgery, but it's still a non-fusion surgery. So I think that's a really good choice. And in a select group of people, I can see going down that road if you're facing a DroSakhalin stimulator trial versus a lumbar fusion. Both things are kind of a big deal for patients with just discogenic low back pain, but it's not unreasonable. It's gotten a lot better. I have another question here that is very common. Somebody said, I have pain in my buttock and hip, and they've been told it's not a hip problem, it's probably a back problem. So this is probably a question for Chad, and I see this all the time. I even have a video called why my hip and butt hurts. But can you kind of touch upon that? Why so many of our patients have that pain in our gluteal sulcus, like what we call piriformis syndrome? Why so many of our patients have greater trochanteric tendonitis, IT band syndrome, PSIS tendonitis as a result of a back problem, and how you deal with that?
So I'll paint that kind of a broad picture. First of all, with hip pain, I try to differentiate between hip pain generated from the back and hip pain actually generating from the hip. And rule of thumb, posterior hip pain, gluteal, lateral hip pain typically is related to your back. Anterior hip pain, pain that refers into your groin, typically is from your hip joint. And we can obviously confirm that with x-rays and limited hip range of motion for hip pain. But in general, why we get pain from your back into your hip, to your IT band, to your bursa, as you talked about. One, I think a lot of it is due to lack of recruitment of those glute muscles. I see it all the time with lumbar stenosis in men, especially. We lose our butts. I say that's why we have suspenders. We physically, anatomically begin to atrophy in our hips and our glute muscles. And when we're not recruiting those muscles that actually posteriorly stabilize our spine, we start to get pain in our backs and our hips. So a big focus, core is not just your stomach, core is your hips and your glute muscles as well. It's a huge reason why people have back pain is because they really have no strength in their hips and their glute muscles anymore. So when you don't use those muscles and you start to atrophy, then the bursts of the IT band, all those things start to try to accommodate, and they get tight and they compress your bursa. So it's a syndrome, if you will. It's one thing leads to another. So getting back to flexibility and strength of your hips and your legs is just as important as the rest of the core muscles. And so by identifying that and getting exercise that specifically target that area, we've had good success.
Yeah,
So
I think it's kind of like a chicken and egg argument.
Correct. Yeah. Yeah. So is it common with non-specific back pain? Absolutely. It's a very common.
Yeah.
We have several questions about whether stenosis kind of can come and go with the symptoms flaring up.
Do you want to tackle that, Dr. Miller?
Oh, sure. Spinal stenosis, yeah, I mean, it can be episodic. I mean, the more common clinical presentation is kind of a slow, kind of insidious presentation. The spine is very good at accommodating the stenosis or narrowing over time as long as it happens slowly. Traumatically is a different story. That's a disaster. But you know, eventually it'll get to a point where the body can just no longer accommodate for it. And, you know, it'll be something that you're going to have to treat. One of the theories is that the arterial system of the body is high pressure. It pumps blood in when you're walking into the spine. The veins which drain it out are low pressure. They just can't drain the blood out fast enough. So you get this venous congestion in the central canal of the spine. There's other theories about why it happens, but that one, you know, it seems pretty intuitive. And when you sit down, you let the blood drain, the congestion goes away, you get better. That's a condition that there are some minimally invasive treatments, but more traditionally it's been treated by surgery. And Dr. Kim can talk about that.
Hey, can I add something to that, Joel?
Oh, please.
The question was, this individual was saying that he was controlling his symptoms with swimming 3 times a week and going to the gym 3 times a week. Then when pandemic hit, then he dropped those, and now his symptoms have gradually increased, even though he started swimming, but he just started swimming 1 time a week. So we see this a lot with this pandemic. People are not doing their usual exercises, and when they stop those, then they start to atrophy, like Chad was mentioning before, is that they start to atrophy. Now they don't have the stability of the spine, and so now it's less stable, and activity is going to bother you more. So the treatment for that is we want to get into therapy when we want to stabilize the core, and once you stabilize the core, now you want to get back into your cardiovascular exercise like you're swimming gradually, because if you don't swim for 3 weeks and then you go try to do your swimming 3 times a week, you're going to get sore with any activity. So you need to gradually increase that activity after you have the stability to do so.
Good point. Yeah.
Very good point. And yes, I mean, I think there's also the body's state of inflammation. So many disease states, at least in my practice, people have waxing and waning clinical pictures. They'll have good periods of like good days or good weeks and bad weeks, good weeks and bad weeks. It's very common, even with stenosis. Okay, we have like 10 minutes left.
Let me make one quick comment on that as well.
Say that again?
Oh, I was going to make one quick comment on pain fluctuations as well. As you know, most of these are inflammatory responses, I find. And if you delve into and ask enough specific questions, there's usually something that set it off, like you referred to before. And a lot of times it's a day or two prior. And once you can find what triggered that, there's usually an inflammatory response. So certainly these can fluctuate. You have good days and bad days. And really the goal is this multi-team approach we're talking about is to manage these problems. And you know, often with pain management, sometimes that gets us back to therapy, gets us over the hump so they can do more once their pain is controlled. So I think this whole team approach is really important to point out as well.
Yeah, and God bless you guys. You guys do a great job, and we really appreciate physical therapy. Get in there and strengthen the muscles around the spine. Like I think Dr. Kim said, that's the best stabilizer there is.
Okay, we have like 10 minutes left or 8 minutes left, so we have a lot of questions about surgery.
One of the questions
especially fusions, even though the topic is non-fusion surgery. But let me try to address that in 5 minutes, and then we can open up to more questions. So when is surgery recommended? I'm dying to know what your guys' thoughts are, but I would say that when a patient comes to me and they ask me that question, when is surgery recommended, there's a couple of easy answers. The easy answers are when there's a medical condition like a neurologic deficit, a fracture, instability, cancer, or something like that. Then the answer to when surgery is appropriate is relatively easy. When it's really difficult is when we're talking about that big group of patients that have this nonspecific low back pain, because they do not have a neurologic deficit, they do not have a limb or life-threatening ailment. They have a condition that is mainly related to pain and disability. So that threshold varies from person to person. So some people, a little bit of disability is a huge deal to them. So a high-level professional athlete that relies on their physical abilities to make a living, they don't need much to warrant surgery because they need to perform at a very high level. And then from there, it goes all the way down. For the vast majority of us, it boils down to kind of when are we miserable enough that it's worthwhile pulling the trigger for surgery. And I would say that it's when you say something like, my quality of life is significantly affected because I used to love doing A, B, and C, and that's what makes my life full and rich, but now I can only do A, and I've had to eliminate B, and now lately C. And when you get down to eliminating 2 out of the 3 things that bring joy to your life, work, leisure activities, and day-to-day activities. So leisure activities are like going on vacations, playing golf with your friends, going shopping, whatever it is that you enjoy doing. If 2 of those 3 things are affected, then most likely, and you've tried everything reasonably, tried everything to a reasonable extent to take care of this without surgery, that would be a reasonable time to do surgery if there is a reasonable surgery, because there's many different ways to do the surgery. The most common surgical treatment for low back pain is fusion, followed by disc replacement surgery. And I'm not including DroSakhalin stimulators and injections and things like, and some of these kind of weird stabilization surgeries. I'm talking about the majority of patients. Those surgeries require a significant period of time where you're off work, where you're focusing on getting better, and there's a fairly extensive recovery depending on the magnitude of the surgery and if the surgery is done open or minimally invasively. But a fusion surgery generally takes at least 6 weeks for a recovery. So I tell most of my patients, plan to take 6 weeks off work, and then depending on how demanding your work is, you have to start back very gradually. So if you're talking about a fusion surgery, the threshold for triggering an operation is much higher than if you can do a small surgery, because one of the surgeries that is relatively new that very few surgeons have yet to adopt is the laser endoscopic surgery, in part because it's very technically difficult to learn how to do. There's a huge learning curve, and most insurance companies don't recognize it as accepted treatment. They'd rather that you have a fusion of all things. So those 2 barriers have made it so that most surgeons don't offer that surgery. But I would say that when I ask the following question, what would I do if I were in your shoes or you were my family member? That question in my mind helps a lot, cutting through all this fog and looking at that patient and saying, at the end of the day, if I were you, I would do X, Y, and Z. It's surprising how easy that answer comes to me. It requires some getting to know the patient, but I would say that very few spine surgeons that I know have a lumbar fusion for axial low back pain. So think about that. There's thousands of spine surgeons. I know hundreds of them, and I don't think I know a single one that's had a lumbar fusion or disc replacement surgery in the lumbar spine for axial low back pain. They all had it for something like spondylolisthesis or recurrent disc herniation or degenerative scoliosis, something that involves instability or deformity. Because if you do fusion surgery, that's what you're fixing, instability or deformity. So that threshold is huge. You'd have to basically have only one out of the three things that bring you quality of life, and the one remaining thing is also being affected, to the point where your desire to climb the ladder is affected, or you may be looking at losing your job, or at the very least, having all your coworkers looking at you like you suck. That's probably enough to warrant a fusion surgery if you tried everything reasonably. But for the vast majority of us, you can kind of keep up the work part and then let everything else suffer. That group of patients, probably fusion surgery is not recommended, except in rare cases. But if you do have like an annular tear or something like that, laser endoscopic surgery would be reasonable to consider, keeping in mind that it's a relatively new procedure, not covered by insurance. And I don't want to go on and on about that because I don't want to make this webinar a surgery webinar. I just want people to get a general sense of where we're at in this population of patients. So there's vast majority of people will get non-operative treatment. The majority of those patients will struggle until they come to a webinar like this and get reinvigorated to really pursue non-operative treatment in a meaningful way. And in my estimation, that requires a significant commitment. I tell my patients, you go to physical therapy, but when physical therapy ends, your hard work starts, because physical therapy is not a destination. It's the start of a journey, and your physical therapist is helping you develop a customized, long-term maintenance, exercise, fitness program. They're almost like your life coach for low back pain, with people like Dr. Miller and Dr. Anthony kind of managing small things to kind of help things along. And only rarely do those patients then come to me when they've exhausted all those non-operative treatments. And then, I strive to have a toolbox of variety of different treatments, including lots of kind of state-of-the-art treatments, because most people I wouldn't feel comfortable recommending a fusion for low back pain. And that's why I'm constantly looking for other ways, because the concept is simple. If I'm not going to do it for myself or my family, I have a really hard time recommending that to my patients. So I think most of us think like that, and I hope that everyone that's attending the webinar is kind of getting that message home. So it's exactly 6 o'clock. We have some more questions. If everyone's okay with another 5 minutes of Q&A.
Sure.
Is that okay?
Sure.
Okay, so here's a question that I get asked a lot. A patient has been recommended to have a disc replacement at L4-5 and a fusion at L5-S1. Is it advisable to take the replacement first and see if that fixes most of the issues with pain and wait years for the fusion? Okay, so that question is a challenging one, because if you have two levels of a problem, if you just fix one, you may not get any better, because it's not like you're going to get 50% better and the other level is going to provide 50%, because it could be that one of the levels, if you leave them untreated, will remain symptomatic, and from your perspective, it'll be like nothing happened. And doing two surgeries near the same location, back to back, is challenging, because the second operation is a revision operation, so depending on how it's done, you can run into a lot more scar tissue. So I would say that if you're going to do a surgery as big as a disc replacement or a fusion surgery, make sure that you've gone through all the things that we talked about, that you feel comfortable, that you've pursued non-operative treatment in a meaningful way, and you've committed to trying that before you undergo a surgery. And I would explore some of the non-fusion options before undergoing a surgery of that magnitude.
Hey, Dr. Kim, just to interrupt, how good is insurance coverage on disc replacements for the lumbar spine? I know it was a little spotty for a while. Is it better now?
It's much better now, in part because Blue Shield lost a large class action lawsuit because they were really strict about saying no to disc replacements. So I think it's getting better, but it's still difficult to get a disc replacement approved.
Gotcha.
think we have one
Do you see any other
phone.
questions, Jennifer, that we should address before we sign off?
Let's see if Helen is on there. Nope. It says she can't do that. Okay.
So to end, I want to paste in here, or maybe I'll do that, a bunch of information so that after today, if you have questions for us, you can reach out to us. So look at your chat box. We'll also send you a follow-up email with some contact information of all the faculty. And then I put in some links to some YouTube videos that talks about non-fusion surgery for low back pain. And if the other faculty members want to type into the chat box some similar links, that would be totally awesome. And with that, I'd like to just say thank you to everybody. And I hope that we can do this again in the future.
Thanks very much.
Thank you.
Thank you.
Take care, everyone, and be well.